Good afternoon, everyone. My name is Alberta Noonan, and I'm from the New England QIN-QIO, and I'll be your moderator for today's webinar. QPP 2019, the proposed rule, what you need to know now. Before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. At that time, I will provide you with instructions on how you can ask a question over the phone. You can also pose a question in the chat box throughout the presentation. Please make sure to send the question to all participants. At this time, I'm going to turn this over to our presenter, Leila Volinsky. She's the Senior Program Administrator and the New England Regional Lead for the Quality Payment Program for eligible clinicians for the New England QIN-QIO. Leila, there you go.
Thank you, Alberta. Good afternoon, everyone. Thank you for joining us today. As Alberta said, our presentation today is around the Quality Payment Program Year 3 Proposed Rule and what you need to know now. Let me just advance the slides. There we go. So, Quality Payment Program Proposed Rule today. Just a quick disclaimer, all of the materials are based on CMS documentation, but we did create these, so if there's any inconsistencies, just know it was in error on our part. I'm going to jump right in. I have a lot of slides, there's a lot of content, and I want to allow plenty of time to end for questions. I just also want to remind everyone that this is a proposed rule. So all of the different changes to the program that I mentioned are just proposals. And if you're familiar with the way the Quality Payment Program has worked over the last couple of years, there typically have been pretty significant changes between the proposed rule and what gets finalized sometime end of the year, usually around November. Also, I don't actually have a slide for it this year, and I apologize. If you do have questions or you want to make comments, public comment on the proposed rule, CMS has the window open until September 20th, and we will put that link into chat so that you can access the public comment portion. But if you have anything that you think needs to be changed or you really think that a different portion of the proposed rule makes sense, please let CMS know. They take your comments into their consideration, and if you really like something or want something changed, it's important to make that known now while there is still time to change that. So the first major component, shouldn't really be a big surprise, is that the performance threshold is scheduled to increase to 30 MIPS points. Currently in 2018, it is set at 15 MIPS points in order to avoid a negative penalty. Also in 2019, that negative penalty, which comes out of your Medicare Part B claims, goes up to 7%. As many of you remember, the way MIPS works, the Merit-Based Incentive Payment System, those of you that don't meet the performance threshold or don't report any information to CMS would get a negative 7% penalty. There is a tiered process depending on the number of measures you submit and the amount of performance points you earn, where you could get potentially less than a 7% negative payment adjustment if you did submit just one measure or a couple measures and didn't quite meet that 30 or 15% performance points threshold for 2018, 30 points for 2019. There is also the potential for up to 7% positive payment adjustment. Now, we've seen, since a lot of our clinicians have received their 2017 performance feedback reports, that the total amount of increase you're expecting to get probably is not going to be up to 7%. CMS is targeting the highest positive payment adjustment, including whatever you get in terms of your MIPS points and any exceptional performer bonus that you're eligible for, will be somewhere around a cap of about 5.6%. So just know if you perform extremely well in the program, you get the maximum positive payment. It's only going to be somewhere around the 5.6%. Now, that's also taking into consideration that MIPS is a budget-neutral program. The only money that goes for positive payments comes from those who have negative payments. For 2017, there was a 91% participation rate. So as you can imagine, with 91% of clinicians participating, only 9% received a negative payment adjustment. So that's where those positive payments are coming from. For those of you who did extremely well in 2017, you're probably aware that you got about a 2.02 positive payment. That's for those that performed at the 100 of 100 MIPS points. So just know 5.6 is what they're targeting for 30 MIPS points to avoid the penalty. As I mentioned, the exceptional performer bonus. So currently, the exceptional performer bonus is set at 70 MIPS points. You have to earn at least 70 MIPS points in order to be eligible for that pool of $500 million. There's an algorithm that determines how well you perform, the size of your practice, a whole bunch of different things come into the equation. For 2019, that exceptional performer bonus has bumped up to those clinicians and groups that earn at least 80 MIPS points. So just know that you do have to perform a little better to get a little more of an incentive. So here's a kind of significant change. The numbers haven't changed a whole lot, but there is a third component being added to the low volume threshold. So currently the low volume threshold for clinicians and groups that will be participating is you must have at least $90,000 in Medicare Part D professional services, and that only looks at the charges coming from the physician fee schedule, and you have to care for at least 200 Medicare eligible beneficiaries. For 2019, those two equations stay in place, so $90,000 in Medicare professional services and 200 Medicare beneficiaries. There's a third component being added, which is the total number of Medicare professional services. So those are services being provided to those Medicare eligible patients. And in order to be eligible, you have to also have 200 or more services. So now there's three components. In order to be completely eligible, you have to meet all of those three components. So you have to be above on all of those different components. If you're not above on one or two of those components, so you have fewer than $90,000 in Medicare professional services, you have under 200 Medicare professional services, or you see fewer than 200 Medicare eligible beneficiaries, you would be excluded from reporting to the MIPS program in 2019. Now, unlike the program as it currently stands, there is the option potentially to participate. So eligible clinicians and groups that meet one or two of those three components of the low volume threshold do have the option to select whether or not they would like to participate. So currently in 2018, if you're below the low volume threshold, you have the option to submit data, but you can't actually participate in the program. If you submit data to CMS, you will receive a score, but you're not eligible to receive any sort of positive or negative payment adjustment. In 2019, if you are below one of or two of the low volume threshold components and you choose to participate, you are then eligible for either a negative or positive payment adjustment. Now, I would highly recommend, if you're choosing to participate, that you have probably high level of participation and you're going to achieve, probably 80 plus MIPS points, that you're going to max out as many possible positive payment dollars as you can, but just weigh that option. Also know that in order to participate, there is an election process. CMS won't automatically assume that you want to participate. You do have to log into the portal, which is found under the CMS, QPP.cms.gov website, and then decide to choose to report. That option isn't currently available right now, but if you choose once this is finalized, if this gets carried over into the final rule, that would become available for you. Pretty significant change, only a month, but it does, the dates didn't change in the beginning part, but the eligibility determination. So changes to eligibility determination is that it used to be from September 1st through August 31st of whatever year. Now it's moved from October 1st, and I apologize, that says 2016, it should say 2017, through September 30th of 2018, and then the second would be October 1st, 2018, that should also be changed to September 30th of 2019. So you can see it all shifted a month a month forward. And this is to align more closely with some of the other determination windows, so some that are used in the hospital. There's also a reduction in the claims run-out period. For 2018, a 60-day claim run-out period. Going into the 2019 performance year, it would only be a 30-day claim run-out period. So just a slight shift in the determination timeline, but it does align more closely with some of the other determinations used for CMS. This is a pretty big one. If you have clinicians in your practices that are under these eligible clinician types, it's really important that they start preparing now. More than likely, there will be some new eligible clinician types carried over into the 2019 final rule. It's hard to say exactly who, but for right now, it looks like CMS will likely finalize physical therapists, occupational therapists, clinical social workers, and clinical psychologists will be considered eligible clinician types. There has been talk that speech and language pathologists, qualified radiologists, certified nurse midwives, registered dietitians, and nutrition professionals would also be included. But there's been a lot of talk about the fact that there are not necessarily the appropriate number of quality measures available for these clinicians, and that since they'll only really be evaluated on quality and improvement activities, it's critical that they have enough quality measures to sustain high levels of performance. As you can see at the bottom in this note, these eligible clinician types, whether it's all or just the top 4, receive automatic reweighting in the promoting interoperability performance category. So similar to nurse practitioners, NPs, certified registered nurse anesthetists, and clinical nurse specialists, as well as those hospital-based and non-patient-facing clinicians, these clinicians automatically have their score for promoting interoperability reweighted to 0, making quality 70% of their score, and I'll talk about the categories in just a moment. So for the MIPS performance category scoring in 2019, the proposal is that quality reduces to 45% of the MIPS score. Oops, I apologize, I shouldn't say advancing confirmation, say promoting interoperability. That remains at 25%. Improvement activities also remain at 15%, and then cost increases from 10 to 15%. So quality will continue reducing by 5 percentage points as cost continues increasing by 5 percentage points until we get to cost at 30%. That would also make quality 30%, so cost and quality will equal in just a couple more years based on how it's looking with the proposed rulemaking. This was a bit of a shock for us. We really expected that CMS would change the quality reporting period, but it looks like it's going to hold steady at a full calendar year of data. We had kind of expected it to shift to the 90-day reporting period. Now again, if you have strong comments on this or believe it should be 90 days, please make sure that you submit those comments to CMS. I, again, apologize. It says advancing care information. Clearly, those were missed. Quality, so as a full calendar year, promoting interoperability listed as advancing care information is at least 90 days. Improvement activities remain 90 days, and cost is also a full calendar year. CMS, as you know, loves to change acronyms and the naming of different elements. So within the program, there's some significant changes proposed for the way that data submission types are referred to. So the first is there's a new category called collection type. And this is the type of quality measures that you select. And this is based on the specifications and data completeness criteria. So the first is ECQM. If you're familiar with EHR reporting of quality measures, those are those measures. So those come right from your health information technology or certified EHR system. The next is a new component. This is MIPS CQMs. Those were formerly known as registry measures. So those qualified clinical data registry measures are now called MIPS CQMs. Anyone using the qualified clinical data registry measures remain QCDR measures. If you're using the Medicare claims-based measures, those remain claims-based measures. Same with CMS web interface measures, the CAPS for MIPS survey, and then any group that's 16 or more that has the administrative claims all-cause readmission measure has that same administrative claims measure. Now, the submitter type is the individual or individuals that submit data to CMS to meet the requirements of those given measures under whichever collection type you selected. The first is MIPS eligible clinician, so that would be just an individual clinician. The next is a group, and the third is a third-party intermediary acting on behalf of the clinician or group. So that would be your registry vendor or any other data submission vendor that you might be utilizing. The third new data submission component is submission type. So this is then the mechanism by which that submitter that we just talked about submits the data for each of the different collection types. So the first is direct, and that's typically using an application programming interface or API. This probably would be likened to the EHR direct reporting. The next is login and upload. So this is going through that CMS portal. The next is login and attest. That's also going through the portal. The third is using the Medicare Part B claims measures. And then the fourth is, actually technically the fifth, is the CMS web interface. A couple changes to keep in mind. So for individual clinicians for quality, you can submit data using direct, login and upload, or Medicare Part D claims, and that's for quality only. For promoting interoperability and improvement activities, you can use direct, login and upload, or login and attest. For group submission, you can use direct, login and upload, or the CMS web interface. And for promoting interoperability and improvement activities, you have the same options of direct, login and upload, and login and attest. Any of you that previously used the CMS web interface for submission in 2017 are probably wondering why it's not listed for promoting interoperability and improvement activities. CMS is considering not allowing the submission of data for those two performance categories through the CMS web interface because they believe that it was initially intended to collect quality measure data alone. And so since there's the portal or other mechanisms to submit that data, they've removed that as an option for data submission. So just keep that in mind if you're planning on using the CMS web interface. Along the lines of the evaluation period, CMS is also proposing to finalize a policy that would keep the data submission for all of the different components, so whether you're using direct, login and upload, login and attest, claims-based, or CMS web interface, the same. So you would begin no earlier than January 2nd of next year, 2020, I should say, and run for 8 weeks, which will bring it right to March 31st. Those of you that use the CMS web interface know that that timeline was a little different in 2017. So the goal is to get these really aligned with one another so there's less of an administrative burden, the measures align a little more easily, and teams don't have to do quite as much maneuvering. There's also a component of data submission where CMS is considering allowing groups of 16 or more eligible clinicians the ability to report through the CMS web interface for their quality measures. Now, if you're familiar with the CMS web interface, it's currently restricted to accountable care organizations and alternative payment models and groups of 25 or more eligible clinicians. So by changing that, there will be some additional clinician groups that might have interest in utilizing it. Because there is a high case volume requirement, there is a belief that these smaller groups might not meet the case reporting requirement, so they might have a smaller subset of measures. Again, this is only a proposal, so it's hard to say exactly how this will all shake out, but that's in consideration. Big change for claims-based reporting. CMS is considering only allowing claims-based reporting of quality measures for clinicians in small practices. So those are clinicians in practices of 15 or fewer eligible clinicians. Currently, in 2017 and 2018, any eligible clinician reporting as an individual may choose claims-based reporting for their quality measures, but for 2019, there is a proposal that this would move only to those in small practices. CMS is also considering the addition of some group claims-based reporting measures. Again, proposal, it's not entirely clear exactly what those group measures would look like or how that would all function, but there is consideration of allowing groups, small practice groups, to report claims. For the cost category, I'm going to say small but relatively significant changes. So as I mentioned, the cost category will go up to 15% of your MIPS score. You'll continue to report on the Medicare spending per beneficiary, MSPB measure, and the total per capita cost measure. There have been 8 episode-based measures added, or at least proposed. I'll talk about those measures now. Oops. Sorry, I just want to get to those measures. Here we go. They got pulled down. So for the episode-based cost measures, these are the measures. There's the elective outpatient percutaneous coronary interventions. That's looking at the PCIs. That's a procedural measure. There's also the knee arthroscopy procedural measure, revascularization of lower extremity chronic critical limb ischemia procedural measure, routine cataract removal with intraocular lens implantation procedural measure, screening and surveillance of colonoscopy procedural measure, and then there's 3 acute inpatient medical conditions. So these are really looking at those inpatient encounters. Intracranial hemorrhage or cerebral infarction, simple pneumonia with hospitalization, and ST elevation myocardial infarction STEMI with percutaneous coronary intervention. So again, another PCI. You can see they have clearly some strong emphasis on cardiac conditions. I'm guessing the lower extremity chronic critical limb ischemia has something to do with diabetes or poor vascularization. Let's see, the intracranial hemorrhage or cerebral infarction, probably related to their stroke measures. Knee arthroscopy, ortho, and cataracts obviously goes back to eye conditions, and pneumonia is a separate component. So some clear focus on some of those measures. I apologize, it looks like my slides got a little out of order, so I just want to go to the next slide. So based on these 8 episode-based measures, there is a slight change to the attribution for those measures for patients. So the procedural episodes will be attributed to eligible clinicians that have that rendered the trigger service, so whatever that initial trigger service was. For the acute inpatient medical condition episodes, those get attributed to the eligible clinicians that build that initial inpatient evaluation and management code. Now, this has a kind of funny component to it. So those clinicians belong to a TIN. That TIN must have rendered at least 30% of the total inpatient evaluation and management claim lives during that hospitalization. If your TIN or that specific TIN rendered under the 30%, that inpatient encounter would likely be attributed to a different clinician or TIN. Similar to the MSPB and PPCC measures, there are some case minimum requirements. So for the procedural measures, you must have at least 10 cases. And for the inpatient medical condition episodes, you must have at least 20 cases. I apologize, I'm going to up back a little. So for quality, CMS, some kind of interesting changes to the quality component. So obviously, I don't have it here, but quality is being reduced to 45% of the total MIPS score. CMS is considering this implementation of a new scoring system. So basically looking at the kind of the value of those measures and scoring them based on gold, silver, or bronze. That might hold, that might not hold. So really looking at, for those gold measures, the measures that can earn you the highest possible performance score, how do they align with outcome measures or composite measures or those priority areas such as opioids or patient experience? So really looking at that high performance or high priority group and identifying ways to say that these measures really should be scored more highly than other measures. This is coming from that Meaningful Measures initiative and identifying ways to make sure that clinicians are reporting on measures that are truly meaningful to them. Not going back to always reporting on process-based measures that are simply looking at, did you do this assessment and did you document it? Really making sure it's closing those gaps, making sure patient care is improving, and all those different components we've been looking at. Now, it's unclear whether this will get passed in the final rule or not, but just keep it in mind. It's an interesting way to score measures, I think. For the moment, measures will continue to be scored on the 0 to 10 point decile score, with measures that have no benchmark still earning 3 points, and depending on whether you meet the data completeness requirement or not, large practices would earn 1 point and small practices would continue earning 3 points. So still some variation in how they're going to be scored, but more to come on that. Again, this is a proposed rule, so lots of changes might be in store for us in November. This is a pretty big one. We expected it to come. It was talked about in 2018 and pushed off to 2019, so I would kind of imagine that it will get finalized in the final rule. So there is talk of allowing the facility-based measures for quality and cost to be utilized. So this is for clinicians and groups that want to utilize the hospital-based, value-based purchasing measures in order to report on quality and cost measures. They kind of align nicely. So CMS has identified that eligible clinicians and groups that fall into the inpatient setting can utilize these scores rather than having to report on additional measures or whatever the case might be. Now, the proposal does include so there would be automatic application of these facility-based measures for eligible clinicians unless another submission method was utilized. So in this example, let's say you have a hospital-based clinician who does have the inpatient data for hospital value-based purchasing, and they actually submit data using EHR Direct, or that direct method to get quality measure data. CMS will look at the two data sets and say, okay, for the EHR Direct group, they earned, let's say, 40 of the possible 45 MIPS points, and for the facility-based measures group, they earned 42 of the possible 45 MIPS points. Since the facility-based score is higher than that of the direct reporting method, they would earn the 42, and CMS would take the facility-based measure group. So even though that clinician has reported using another mechanism, CMS will take whichever is higher and gives more performance points to that clinician. So it's kind of a nice way to make sure that CMS is really giving you the most points possible. When considering facility-based measures, this goes back to, it should look very familiar to hospital-based clinician eligibility. So CMS will look at clinicians that furnish at least 75% of their covered professional services in place of service 21, which is inpatient hospital, 22 on-campus outpatient hospital, or 23 emergency department. And that's going back to the current determination period of September 1st through August 31st of 2017. Interesting component to this, there's a lot of talk about whether or not to allow just place of service 21 and 23. Obviously, those are really the two inpatient locations. But CMS did consider including 22. The only caveat to that is that you must have at least one service billed in place of service 21 or 23. So you can't have only place of service 22. You have to have at least one in 21 or 23. The other component is you, not surprisingly, have to have a hospital-based value-based program total performance score in order to be eligible to utilize the facility-based measures. If you don't have a value-based payment program score, there's really nothing that CMS can draw information from and couldn't account those quality and cost measures to. There's been a lot of talk about the validation and applicability. So looking at measures for clinicians that are specialty clinicians, how does CMS determine whether or not other measures were applicable and should have been reported on? This process is really confusing and it's kind of hard to tell. So really the way it works is that CMS does an evaluation of the total measures, your clinician type, and says, okay, were there additional applicable measures? If yes, then your score would hold. If no, then you might actually have a reduction in your score, which would allow whatever measure you submit data on to earn you more of a score. So let's say you were supposed to report on 6, only 4 are appropriate. You only reported on 4, then you could get the highest possible score because you're reporting on 4 of 4 rather than 4 of 6. So kind of weird. CMS is talking about removing this sort of eligibility component and considering moving to more of the specialty measure sets or data sets that really only have measures that are applicable to that measure set and that clinician type to remove that validation and applicability component. Again, proposal, hard to say whether it'll get finalized, hard to say what it'll look like come 2019, but just keep that in mind. I'm going to jump past costs. Everyone's favorite, promoting interoperability. So again, this was previously advancing care information. Not surprisingly, CMS has proposed that all eligible clinicians and groups must use a 2015 certified EHR system in 2019. This was initially supposed to go into effect in 2018, but clinicians got an additional year to upgrade from 2014. There are still hardship exceptions. Those will be available at a later date, and you must submit by December 31st of 2019 in order to be eligible. Again, since this is a proposed rule, that eligibility determination and application is not yet available. Just a side note to that, if you are reporting for 2018 and you believe you should be getting a hardship exception for promoting interoperability, please make sure you stay on top of that application for 2018. They are separate program years, so you do have to resubmit an application each year, and so the final date for that submission would be December 31st of 2018. So just keep an eye out. We can help you if you have questions, but make sure you're checking that out. So with the change in the name, Promoting Interoperability, back in April, there was also some significant talk of changing the objectives and measures. And really the goal was, as the name suggests, to promote interoperability of systems. So these measures should look somewhat familiar but a little different. So the proposed, and I apologize, Sam, I have some typos in here. So it should say 2018, it should say 2019, promoting interoperability measures. So the objective is electronic prescribing. Under that is the same measure of e-prescribing. You can earn a maximum of 10 points. There are two new measures, which are querying the prescription drug monitoring program, which would get you a 5-point bonus, as well as verifying an opioid treatment agreement, also a 5-point bonus. So within this component, you can see that CMS clearly has a focus pretty honed in on e-prescribing and making sure that any patient that's getting a Schedule II narcotic has had the prescription drug monitoring program at least evaluated. And then the opioid contract agreement is really looking at those patients that have had at least 30 days, doesn't have to be a concurrent 30 days, could be a smattering of 30 days during the reporting period of opioids prescribed to them, that they have an opioid treatment agreement on record. As you can imagine, with the high level of opioid addiction, it's really important to make sure that patients are being identified and treated appropriately, and where possible that Schedule II narcotics are not being given out if not necessary. The next component is a pretty big one. It shouldn't look very different. The names have changed a little, but they're still pretty much the same measures. The first is the Health Information Exchange objective. The measure is support electronic referral loops by sending health information. So really, this is looking at that send and receive of the summary of care. So it's making sure that that summary of care document is being sent between clinicians that are referring back and forth with one another. It receives a maximum of 20 points. The next is the support electronic referral loops by receiving and incorporating health information. So similar to the request and accept and then integrate that data into your system, this is where CMS is expecting you to take the data you receive through those electronic summary of care documents and actually incorporate it into your system in a meaningful way. Now, what happens if none of the data is up to date or it doesn't match up or whatever the case is? Just make note that you have received the data and maybe you have more accurate data because you saw the patient or whatever the case might be. This measure can also earn a maximum of 20 points. I want to briefly mention, as I go on to the next set of measures, that the security risk analysis is not listed. While it's not listed, it is an unscored but required element. Much like the attestation, for those of you that have attested to the Promoting Interoperability or formerly Advancing Care Information category on the portal, you have to attest to the information blocking. You have not done that, and there's a couple other ONC attestations that you complete when you submit your data. The security risk analysis is still included in that. You must have done it. If you say no, you would fail the required component of this category. So it's still required. It's just not a scored element. The next, provider to patient exchange, slightly different objective name, but should look very familiar, so provide patients electronic access to their health information. That's the portal. Whatever that looks like in your practice, whether you're using a formalized portal module or an API, you can get up to 40 points. As you can see, CMS putting a heavy weight on that one, making sure patients have access to their data. For 10 points, you can submit data to a public health or clinical data registry. You must submit to 2 of the following in order to receive the 10 points. You don't get any more than 10 points for submitting to all of them. There are also exclusions based on what's applicable in your state. Some states can receive data, some states cannot. Just take a look. So as you can see, there's a total of 110 points available for the Promoting Interoperability category now. Within those 110 points, 10 of them are bonus, And each of the measures is now scored based on the numerator denominator. So if you have 50% performance in, let's say, the provide patient access, you would earn 20 of those possible 40. So it's no longer that you earn a full 50% of the category just by meeting the base requirements. You now actually have to submit data, and based on your performance, you get a score. So this is a really kind of significant change in terms of scoring. A lot of clinicians had submit just the base requirement to get that 12.5% MIPS points. Now you really have to have high performance percentages in order to get a high promoting interoperability score. Now, not unheard of if you've been doing this work all along. This really should look like similar measures that you can carry through and continue doing that good work and engaging your patients and other clinicians. As I mentioned, there is a lot of, I'm not going to get into it now, but there's different components that if you're excluded from this measure because, let's say, you don't do e-prescribing, that 10 percentage points would get reweighted to a different category. There's kind of a crazy reweighting system that goes on. But lots of opportunities. I think CMS finally heard from clinicians and groups that utilizing the EHR can be challenging, and that it's important to recognize the efforts that are taking place and those that might not be available based on the system and whatnot. So lots of reweighting. If you have questions about that, I'm happy to go into them at a separate time. There's just too many to cover right now since I only have about 24 minutes left. The other piece that's really important to keep in mind is that for the proposal, for those two elements, they haven't actually required that the query of the PDMP and the verified opioid treatment agreement are required, but there is talk about requiring them in 2020, so 1 year from now. But also keep in mind that, as I mentioned, if a clinician cannot e-prescribe controlled substances under their state law, because some states don't allow Schedule IIs to be e-prescribed, that you would be excluded from those two measures and they would be reweighted to the general e-prescribing measure. So, again, CMS really understands that there might not be a possibility to report on measures or state laws will dictate whatever the case is, so there's lots of reweighting that's going on. Improvement activities, I don't have a whole lot to say on this. Remains 15%. There's some new improvement activities. There's going to be right around 117 or so available improvement activities based on the proposed rule. The big change really, and I maybe should have put it as the promoting interoperability, is that there's no longer a promoting interoperability bonus for improvement activities that utilize certified EHR technology. Really, the expectation is that kind of you're all using promoting interoperability requirements to, again, promote interoperability, engage patients in their health care, and make their data available across multiple systems and settings of care. So, unfortunately, that 10% bonus is no longer available. Some general components to talk about. So the high priority measure bonus has been removed from the CMS web interface. Really, the way CMS saw this was that because those high priority measures were required, it wasn't really appropriate to give additional bonus points. So those measure bonuses have been removed. Those of you in small practices that will be seeking out the, for 2018, it's a 5-point bonus for small practice participation, really. In 2019, the proposal is to reduce that to 3 points, and it's no longer added to your MIPS final score. It now becomes part of your quality performance category numerator score. So you get a little bump on your quality performance, 3 points if you're in a small practice. Benchmarks will be based on the measure collection type. As you recall, I went through those different collection types. Really, this shouldn't be a surprise. The benchmarks are currently based on the different collection types that you utilize. They're maintaining the data completeness and case minimum requirements. I already mentioned that. You still need to meet the 60% data completeness based on the method of reporting that you select in order to receive the maximum number of performance points for each of those quality measures. Now, interesting. This was kind of a hot-button topic on a CMS call that we participated on. There is talk of evaluating measures where clinical guidelines change mid-year. So let's say, I'm trying to think of a good example, and I don't actually have one right on the top of my head, but let's say something changes in regards to hemoglobin A1C evaluation. I don't think that'll happen because it's been pretty consistent for a while. So let's say it changes, and all of a sudden they go from you want under 9 to you want under 7. And under 7, since that's a pretty significant shift, maybe it's not supported by the measure steward anymore, or whatever the case is. Because this changes potentially the workflow needed to report on that measure, there's been a significant focus on whether or not those measures are still appropriate. Now, if you're in a practice that's planning on, let's say, reporting on the hemoglobin A1C for a control measure, and the performance threshold goes from you want an A1C of under 9 to under 7, CMS would basically just kind of wipe out that one measure for you, so you would not have to report on 6, you'd be reporting on 5, because they understand that it's not always easy to quickly shift directions, retool the system. EHRs might not be able to capture the data the same way. So they're looking at 9 months of data. It's a little bit of a shift. I don't know that this one will get finalized. I think there's a lot of, like I said, it was a pretty hot-button topic when we sat in on the CMS call, just because clinical guidelines, they change, right? And they change definitely mid-year, so wouldn't it make sense to just change it once the year comes and goes? Reweighting, this is a kind of interesting one. So for clinicians that join an existing TIN that were not part of that group previously, or a newly formed TIN in the last 3 months of the year, so that would be October, November, and December, they would have all of their performance categories reweighted to 0 and would receive a neutral payment adjustment. This has caused a lot of concern on parts of groups that we've worked with, because clinicians come and go from practices, particularly the clinicians that are coming in new. So how do they report? Do they have the data available? Are they up to speed? Are they past training? Whatever the case might be. I'm pretty much hoping that this one gets finalized, because I think this would really alleviate a lot of the burden on those last couple months of the reporting year. But more to come on that, and stay tuned if you're in a group that has potential turnover, because this would be very helpful for you in terms of data reporting. All right, some fun about alternative payment models. I don't have too much on APMs, and I want to leave some time for questions, so I'll get through this quickly. So there's a proposal to allow ACO participants, those are those participants under the Medicare Insurance Savings Program track, to submit their promoting interoperability performance data as an individual or as a TIN. Currently, under 2017 and 2018 rule, you have to submit as a participant TIN. This is a little challenging for those clinicians that might not heavily utilize an EHR, or might be a different practice type, or whatever the case might be. So just a little shift to make it a little more equitable, and that appropriate clinician types are submitting the data. I'm sure questions are going to come on this, and we actually are in the process of creating an all-payer combination option webinar. There is the talk of adding the all-payer combination APM group to the different APM models. So under the all-payer combination option, clinicians can use a combination of Medicare participation in advanced APMs as well as participation in other payer advanced APMs to achieve that qualifying QP status. So just keep in mind with this one, you have to participate in a Medicare APM, and you have to have at least 25% of your patient volume or 20% of your claims volume in that Medicare APM to even consider the all-payer combination option. If you hit either one of those two thresholds, then you also have to have, through the other payers, 25% of your patient volume or 15% of your claims volume. You have to meet one of two of those options. So either 50% patient volume or 35 claims volume in order to be considered a qualifying participant under the all-payer combination option. There's lots more to this that I said I'm not going to get into, because it literally could be its own hour-long or more than an hour-long webinar, but we are scheduling something. It will get into the different payer-initiated process versus individual-initiated process, and more details about how this will all shake out. Again, just keep in mind, this is a proposed rule, so lots of changes might come, but I definitely think all-payer combination is here to stay. There has also been some talk about changing the Medicare Insurance Savings Program CMS web interface measures. So there's a proposal to add a fall screening, risk assessment, and plan of care for prevention of future falls. And then actually discussion of removing some measures. So retiring the general fall screening measure, the medication reconciliation post-discharge, the pneumococcal vaccination status for older adults, the preventive care and screening of body mass index screening and follow-up, the diabetes eye exam, and for those of you who are paying close attention, the diabetes eye exam is actually part of the composite diabetes measure, which also includes the hemoglobin A1C port control. Because that's a composite measure, clinicians would only be scored on the one diabetes hemoglobin A1C port control measure, and that diabetes eye exam would just come off. And then also removing the ischemic vascular disease, use of aspirin, and other antithrombotics. There is talk, a lot of talk within the proposed rule about the nominal risk threshold, and that should remain at 8% of revenue. I'm not going to get into the financial piece of it because it's really something sort of outside of our purview. You need to work with your CMMI, Centers for Medicare and Medicaid Innovation Model, contacts around your specific ACO or other alternative payment model contract. But just know there is a lot of talk of that. If you're interested in checking it out, we won't get into that just because, again, it's sort of outside of what we can help you with. All right. We'll get into questions. If you would like to ask any questions over the phone, it's #6. I see a couple in chat that I want to answer. What does Medicare services mean? Does it mean an EC bills for 200 Medicare billing codes? When would this number ever be below 200 beneficiaries? Great question. So I don't actually know what it would be below 200 beneficiaries, right? You would assume for each professional service that you're billing to a Medicare beneficiary, you would have one billing code. Honestly, I don't know, but this has been part of what CMS wants to consider is the Medicare billing services. So it is all services, again, rendered professional services from the physician fee schedule, similar to the dollar amount of the claims. I see that question was asked twice, so that is all the questions we have in chat. Again, feel free to ask your questions in chat or over the phone, and it's #6 to open the phone line. While I'm waiting, I'm just going to jump ahead. We have some resources. My contact information, I'll jump ahead. So we have our newenglandqpp.org website. You can ask a question there. I also have the link to the CMS QPP website. That's qpp.cms.gov. The MIPS participation lookup tool, which is really the QPP participation lookup tool now. It includes APM information, a link to the portal, and a link to the website, resource library site. If you have questions that you don't want to ask in the chat or over the phone, feel free to send those to me via email. Happy to help you out there. I see another question. Are there any changes to eligibility via other payers? I'm not sure exactly what you mean by that. Are you talking about low volume threshold? All other payers have very different requirements. CMS, again, we'll get into that on our other payer webinar, but it's really dependent on those other payer advanced APMs, what their criteria are. But CMS is saying basically if you fall into another payer advanced APM model, that their criteria meets their requirements.
Hello, everyone.
I'm entering into the chat information on the comment period. If you have questions, you can go to www.regulations.gov and submit your comment there, and there's information about that.
While we're waiting for some more questions, I'll just finish up with some of our housekeeping. Thank you all for a great discussion. We have 2 last-minute announcements. As a reminder, we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing your computer with someone else, You'll receive an email tomorrow with a link to the evaluation as well as a link to the event page on our website. The slides are available at the event webpage. Within the next few business days, a recording and transcript of this webinar will also be added. I've put that link in the chat again for you. And thanks again for attending, and have a wonderful day. Leila, I'll turn it back over to you.
Great, thanks, Alberta. We'll stay on the line for a few more questions. If anyone has additional questions, again, you can ask them over the phone or in chat. Oh, I see one in chat. Let's see. Is there any detailed information regarding the query of PMP and verify opioid treatment agreement? Does this all need to be incorporated into the EHR? Oops, jumped to sorry. Or accessed via, this is difficult. Will this default to state requirements? These may be stricter given state-level opioid management. Great question. I actually don't know if they'll default to state-level requirements, but obviously if your state has specific requirements, you would have to follow those. And then in terms of the EHR, so that's really their bonus points. If this gets finalized, if those measures get finalized, those 2 5-point measures are bonus points. So the assumption is that they are incorporated into your EHR in some meaningful way. Now, these are new measures, so I don't know that many EHRs actually have the capabilities of utilizing them right now. So you would get the 5 bonus points if you can demonstrate that you can report on them now. Going forward, they'll potentially be required. So it's really dependent on the EHR and what it can support. So yes, you do need to have it incorporated into your EHR. That's the promoting interoperability measure, is that you're utilizing your EHR. So just keep that in mind. But definitely state-level requirements must be followed. But if they're stricter or less strict, you want to make sure you're following whichever one has the most strict guidelines and that you're doing whatever it requires. We have a few more minutes. Leave the phone lines open in case anyone wants to ask questions over the phone line. Again, it's pound 6, or you can ask your question in the chat. All right, well, not hearing any other questions or seeing any other in the chat, we'll wrap up the call, but thank you all for participating and let us know if you have any additional questions. Thanks again.